the main person is laughter. I'm getting several consultations from patients with the history of loss of weight. And with the difficulty only I convince that they are normal. Because they think that they are abnormal. This is the situation where we are. Many who come for not gaining weight or weight loss are healthier than the overweight counterparts. It has become the rule of thumb that the tertiary care centers are used for primary care these days. We are playing on USA for all the aspects of healthcare, including policy making. One must know that it is the most precarious non-system in the world. Non-system in the world, but we rely only on that. And that has destroyed the problem. We depend on, for every parameter now we take USA as the standard. For example, BMI, blood pressure, fasting lipid profile. And finally, the USA standards has made the whole world a sick society now. This is a reality that we have to wake up to. I will start with one simple case history to illustrate the point of where we are missing the clinical practice these days. This was a 62-year-old male. He noticed a swelling on the left parotid region. As usual, because we encourage doctor shopping, he went straight to an ENT doctor. And he asked for an FNAC, because they think that doing an FNAC will give the diagnosis. And the histopathology reported neoplasm. Then the enthusiastic pathologist himself says for secondaries and primaries. And he thought that thyroid is abnormal. He took an FNAC for thyroid, which reported as pulmonary neoplasm. Then he went to the high-end cancer hospital for the treatment of that malignancy in the parotid and the thyroid, based on a clinical impression and a wrong report. And then at the cancer center, repeat aspiration twice was done from the left parotid. Then he developed severe parotitis and swelling. Since he knew me personally, he came to me for an opinion, what to do now. Because I knew him, I could diagnose him just by looking at his history. He is a chronic alcoholic, and this parotid enlargement was simply due to development of cirrhosis. Unfortunately, the left side was a little more bigger than the right side. Anybody with a clinical skill can say that it was just normal, otherwise it's not a malignancy. And you have all the features of chronic liver disease, which was not looked at or picked up by the habit of doctor shopping that we have. It's a very sad situation. Clinical skill is all about good history taking and good communication skill. 90% of any diagnosis comes from good history only. Even in I see only referred cases. I don't see patient directly. Most complicated case with the non-diagnosed or these days we see. Even in those patients, 90% of my diagnosis come from history only. So that's the importance of history taking. But people are not aware of. Physical examination is only to look for supporting evidences for the clinical diagnosis that we make. And once we have clinical diagnosis, we shortlist one or two possibilities at the end of history and physical examination. Then the laboratory tests are done only to differentiate between those two possibilities. No laboratory test will give a diagnosis. If at all a laboratory test gives a diagnosis, it's only part of the diagnosis. You will get the 90% of the diagnosis, you get the most complicated cases by good history and physical examination. One must remember that no investigation on earth is 100% specific or sensitive. These days, patients come with a different kind of story. Most patients come and say, "Doctor, I have GERD and that." Another will say, "I have polyp in the colon." Another will say, "I have a cyst in the liver." Another will say, "I have a high cholesterol, fibromyalgia. I have a uric acid problem, fatty liver, gallbladder stone." Some patients I get with a history saying that I have low protein CLS. Doctor, what should I do? This kind of consultation has become a routine now because health checkup is being done by laboratories now. And another patient will say, I have headache, all tests were done, nothing could be found out. But only one test was not done, Mendo's scan. That is good history taking. That was not done. That is his reality nowadays. This is what happens. History from today's patient is always corrupted. Corrupted by the investigation reports, the opinions, advice from neighbors, similar patients. So finally the wrong history only we will get. From doctors and also, because of the lack of clinical skill, anyone with a thrombocytopenia without a fever also is now getting investigated for leptoserology and dengue serology. Lepto and dengue are clinical diagnosis only. Thrombocytopenia is incidental. Now for thrombocytopenia, people are asking for leptoserology and dengue serology. This is a common practice now. And I see several patients having PO without P, having psychogenic fever. What is the point of investigating a PO without P? Patient says fever, there may not be fever. So one should know whether his complaint is fever or not. And recently I had two patients who had unexplained hyperpigmentation of skin. Skin biopsy was done to find out the cause. Unfortunately, or fortunately for the patient, it was just due to B12 deficiency, vitamin B12 deficiency. You will not get a diagnosis from investigations. Law back, you will not find a single patient without getting an MRI scan these days. Musculoskeletal pain is the commonest cause. 90% do not even need any of the investigations. Headache, these days invariably get a CT scan. And abdominal pain, everyone will be coming with an ultrasound scan only, but no cause will be found out. Anemia and any abnormality in blood, people think that a peripheral smear and bone marrow will give a diagnosis. It's not true. Even in hematology, where the most difficult situations to sort out, you will not get any diagnosis unless you have a clinical diagnosis. Urinary symptoms, they undergo cystoscopy. Dyspepsia always gets an endoscopy, upper GI endoscopy. And now there is a special term called non-ulcer dyspepsia. Why should it be there? That term itself is ridiculing the clinical skill. There should not be anything called non-ulcer dyspepsia. Dyspepsia is a simple problem, a motility disorder resulting from decreased intake of vegetables. And that can be found out by just studying the lateral practices. And then you do an endoscopy to say that there is no ulcer. Then you have a new term, non-ulcer dyspepsia. There is no ulcer, patient has dyspepsia. How do you proceed from there? Simple history can sort out these things. And bleeding PR, patient goes to with a bleeding PR. First thing done is now colonoscopy. And a colonoscopy detects hemorrhoids. Simple physical examination is enough, history is enough, but it's not done. Arthritis invariably gets joint X-ray, aspiration, MRI scan. TB diagnosis, nobody diagnoses TB without a confirmatory test like AFP, histopathology, or a culture. When in fact, at least 50% of the patients, you will have to do empirical treatment with a clinical judgment. And because I am seeing a lot of hematology problems, this is one problem. All polycythemias invariably get a JAK2 mutation. I can disclose one study report that we are going to publish. Weight gain and chronic hyperventilation